Thank you very much for the kind introduction. I would like to thank the organizers for getting me to discuss on SBRT this year, although it's a bit challenging for me this year because I have to do 3 topics of SBRT within 25 minutes. So hopefully I won't be too much over time. So first of all, I'm going to talk about SBRT for lung cancer. In 2013, ESMO has already published this guideline indicating that SBRT is now considered to be a non-surgical treatment of choice for early-stage lung cancer. And the key is to give it a good dose of BED of greater than 100 grays. And it's saying that peripheral lung lesion is a good indication for SBRT treatment. And for patients with COPD and even older patients, the side effects is quite low. So it's a very good treatment. The rationale behind that high dose of BED of greater than 100 grays is needed is based on the publications from the Japanese, initially in 2007, and there was an update in 2015 as well. Essentially, with this high dose, the local control is better, and there's also a trend of improving in overall survival. Some of the common fractionations that will give a BED 10 of greater than 100 grays would include 48 grays in 4 fractions, as well as 54 grays in 3 fractions. And these are the common peripheral dose fractionations. And for central lung lesions, common dose fractionations will be 60 grays in 8 fractions and 50 grays in 5 fractions. The local control with SBRT for peripheral lesions is usually quite high. Most of the publications indicate that the local control is in the range of 85% to 90%, and regional control is in the range of 85%. Distance control is 80%. And the chance of having local recurrence is usually within, the local recurrence usually happens past the first year after the SBRT treatment. That's the most common median time to occurrence, while regional recurrence occurred around median time frame of 13 months. Distant recurrence usually occur within the first year. The most commonly reported toxicity would be pneumonitis, and most of the data include pneumonitis rate of about 10%, although the high-grade toxicity of grade 3 plus is usually less than a couple %. And these are some of the common dose constraints for lung, and I found the most commonly used dose constraints would be to keep the V20 to less than 6% and mean lung dose of less than 6 grays, and these are quite easily usable. And Onishi also published recently from Astro indicating that perhaps the oldest age or lesions in the middle or lower lobe can increase the risk of toxicity, as well as larger tumor size. Another common another common toxicity reported would be chest wall toxicity. And this is a recent publications presented at Astro this year. And the pooled chest wall pain reported is about 10%. And high-grade toxicity is quite low in the range of 5–6%, and grade 3 toxicity is only 1%. If you keep the chest wall dose receiving greater than 30 grays to less than 30 cc, most of the time you will keep the chest wall toxicity to be less than 10%. Most of you know that for central lung lesions, there's an increased risk of toxicity. So what's the best dose regimen for that? We still don't quite know. And in this study, the author had revealed a number of publications, and essentially what they have noticed is that you can still try to keep the BED 10 or greater than 100 grays with a good local control rate of 85%, while you should keep the BED 3 of less than 210 grays, and in that situation, the mortality should be relatively low. And these are the common fractionations that would fit the above 2 criteria. So 50 Grays in 5 fractions and as well as 60 Grays in 8 fractions will be some of the common dose fractionations for central lung lesions. And BCCA has been using 60 Grays in 8 fractions. The RDUG has also been investigated what's the best dose fractionation for central lung lesions. And they have been starting with 50 Grays in 5 fractions and escalating slowly. As far as I can remember, they reported, in fact, grade 5 toxicities even at dose range of 55 Grays in 5 fractions. So, but to wait for the final results. But I think currently 50 Grays in 5 fractions likely seems to be the safest dose fractionations if we do 5 fractions. This is a randomized studies randomizing patients to have SBRT treatment versus conventional fractionated radiation treatment. And in this study, they have noticed that the patients treated with SBRT has a similar progression-free survival and overall survival. But however, the SBRT patients has less pneumonitis as well as less esophagitis and therefore better quality of life. And also, the Australians also published their randomized studies just recently, a couple of weeks ago at the World Lung Conference. And they also randomized patients to have SBRT versus conventional fractionated radiation treatment. And in the studies, they noticed that, in fact, the SBRT treatment gives a better local control as well as overall survival. And this is the closest studies comparing SBRT versus surgery. As far as I can tell, there's no randomized studies that is complete, but in this study, they pulled the data from 2 randomized studies. Essentially, they show that SABR is likely as good as surgery at a median time follow-up time of 3 years, with similar overall survival and relapse-free survival. And so seems like SBRT is very good comparing to surgery at a short time follow-up of about 3-4 years. So in summary, SBRT is a guideline recommended standard of care, especially for medically inoperable patients. Toxicity appears to be quite low, and central lesions can be safely treated. Although inoperable patients is quite controversial, and likely surgery is still the gold standard for those cases. So moving along, talk about oligometastases. Oligometastatic disease site is a stage of disease where the cancer is spread but not extensively. And so it's hypothesized that eradication of all the sites of metastatic disease could result in long-term survival or even cure in some patients. So the surgeons, in fact, have been treating a lot of oligometastases before the radiation oncologists. And what they have found is that for patients, especially colorectal cancer patients with liver metastases, they have removed some of these patients, the liver metastases, and they have noticed that some patients will have a great median survival of more than 5 years. Similar results for patients with lung metastases for which they have removed the lung mets, and for highly selected cases, some of these patients will live more than 10 to 15 years. And in this studies, it's about 20 to 30% of these patients. So since surgeons have been doing quite a bit of the treatments for oligometastases with the advance in technology, and SABR, the radiation oncologist, started to investigating perhaps SABR can be used in oligometastases. And most of the studies include patients with 5 or less metastases, and the common sites of treatments including brain, lung, liver, and sometimes even bone and adrenals. And keep in mind, these patients are at high risk of developing distant metastases as well. And in some cases, up to 80% of these patients would have further distant metastases. Although if you're optimistic, you can think that, well, perhaps 20% of these patients would in fact not have further metastases, and perhaps these patients could be cured. And in fact, in this study published a couple of years ago at Lancet, the authors have compiled results from a couple of papers for patients being treated with SABR for oligometastases, and the combined disease-free survivals in the range of 25 to 26% at a couple of years follow-up. Comparing to surgery, the SABR treatment or SBRT treatment gives a pretty good local control with a control rate of up to about 90%. So it's very similar to surgery in some situation. Although some studies are indicating that some of the metastases, especially colorectal mets, perhaps is somewhat more radio-resistant, and they have slightly higher increase in local recurrence. While other studies indicating that when they reveal their data, the dose needed to control 90% of these mets, there seems to be similar doses across different histologies. So it's somewhat controversial if colorectal mets is actually more radio-resistant. There are also other factors that would affect the outcome of SABR treatment for oligometastases, and one of them is the use of PET scans. And if you stage patients with PET, it shows that these patients would have better overall survival. It's in fact quite obvious, because if you use PET scan, you would automatically screen out patients with more metastases. So these patients who are screened by PET scans would automatically do better. And patients with more experience in treating SBRT treatment would give a better local control as well. So how do we select patients good for oligometastatic treatment? So a lot of studies has been done, and in these studies, they have noticed that a couple of factors were identified, including good performance status, low number of metastases, small size of metastases. The timing of metastases is important too. Synchronous is usually worse than metachronous for obvious reason, because for synchronous disease, you have to get rid of both the primary disease as well as the metastatic disease. While metachronous, usually the primary tumor has been treated already. So logically speaking, metachronous is usually better than synchronous. And pre-SBRT chemotherapy usually offers a better selection of patients as well. You can imagine that the patient responds to chemotherapy, they're automatically the better selected patients, because the tumor does not progress on chemotherapy, and thus chemotherapy can sometimes be acted as a selection tool. And this is a recent study discussed at ASTRO this year, and they have noted, they have pulled data from a couple of institutions and looked at different prognostic factors, and they have done a recursive partitioning analysis. What they have found is that the best two groups of patients include patients with breast cancer, kidney cancer, and prostate cancers, and another good group of patients would be patients with disease-free interval of more than 75 months. And the worst patients would be the patients who do not have the first two features, while they also have more metastases, and also older patients. Dave Palmer also coined these 4 ACEs, prognostic factors, essentially, again, young age, fit patients, slow-growing cancer. Essentially, metachronous is better than synchronous, also long disease-free intervals, and also minimal disease burden. In addition to those factors, I think that patients with minimal comorbidities and perceived long life expectancies would be better patients as well. The location of metastatic disease should be treatable with ablative therapy. And if the primary disease can be controlled or controlled already, obviously that would be better. And again, certain pathologies seems to be better, including breast, colorectal, renal cell, prostate. They seems to be better than lung. I guess for the mutation-positive lung disease in the future will be proven to be a good selection group of patients to be treated for aggressive treatment, including SABR for oligometastases. And also patients who respond to good to systemic therapy would be a good option as well. So in conclusion, it seems to be there are a lot of promising data suggests that patients with oligometastases can achieve long-term survival with locally ablative therapy. Patient selection plays a key role, and the patients likely benefit from these aggressive treatment will be young, fit patients with low burden of slow-paced disease. There are a number of trials for oligometastases, including randomized as well as non-randomized studies. So hopefully within the next couple of years, we will have more data regarding this topic. So moving along, I'm going to talk about spine SBRT treatment. So conventional palliative radiation treatment has been used for bone metastases with pretty good results. Dose fractionations like single dose of 8 grays or 20 grays in 5 fractions got a pretty good pain relief at 1 month, about 60%. Although there's a minority of patients who may not have good enough response to the treatment, and sometimes retreatment rates for these regimens could be up to 25%. With a higher dose using spine SBRT, perhaps we would improve the patient's quality of life by giving it a better local control and faster and better pain relief, and also durable pain control and less chance of retreatment. Some of the common dose fractionation of spine SBRT include a single dose of 16 to 24 grays, 24 grays in 2 to 3 fractions, as well as 30 to 35 grays in 5 fractions. And that's kind of a dose equivalent to 4 to 5 weeks of conventionally fractionated radiation treatment, and seems to be 2 to 3 times of a dose higher than the conventional palliative radiation treatment. A spine SBRT treatment has been used in a couple of scenarios. It could be de novo treatments, and these investigators have used spine SBRT as an upfront treatment, and they, in the studies, they noticed that the local control is up to 80 to 90%, and complete response rate can be up to 50%, and overall response rate in the range of 80 to 90%. And people have been using post-op spine SBRT as well, in situation perhaps like big bulky renal cell carcinoma causing cord compression, and the patient may be operated by a spine surgeon or neurosurgeon, and people have been trying to give post-op SBRT treatment with a pretty good local control rate of 80 to 90%. Retreatment scenario, I guess, is more of a more common usage of spine SBRT. And again, some of these series have patients previously treated with palliative radiation treatment, and then they have recurrence, and then SBRT to the spine has been tried, and in this scenario, again, they give a good local control of 80 to 90%. The spine SBRT treatment has been shown to give a good local control in different pathology, including radio-resistant disease, for example, like melanoma, renal cell carcinoma, sarcoma. In terms of toxicities, acute toxicities sometimes is pain flare, which can be happening about 2/3 of the patients, although this can be got around by just giving the patients dexamethasone to prevent the pain flare. If the areas you're treating is close to bowels or esophagus, beware that you have to respect those constraints in order to prevent significant toxicities. Sometimes the nerve roots got enough radiation treatment that it will have inflammation, so the patients may have transient paresthesias, but usually it's not quite concerning. For long-term toxicities, most concerning obviously would be radiation myelopathy, but in general the rate is relatively low, usually in less than 1 to 2%. Dr. Segal has published data regarding dose constraints for spinal cord for both de novo treatment and retreatment. Essentially, for first round treatment, you should try to keep the EQD2 dose to the spinal cord or the thecal sac to less than 45 grays range. And for retreatment, the rule is that you should keep the thecal sac dose or the spine PRV dose to less than 25 grays, while keeping the cumulative EQD2 Dmax to 70 grays or less. And there should be enough time gap between the previous radiation treatment to the SBRT treatment, optimally more than 5 months. Again, this is a table showing that what's the spinal cord dose constraints for first round treatment. For example, if you want to give a 5 fractions SBRT treatment, you want to keep the Dmax to 25 grays range or less. If you want to do 2 fractions, you want to keep the spinal cord dose to 70 grays or less. And for retreatment, this is a table guide you of what dose to give for the spinal cord again. For example, if you want to give 5 fractions and the patients you're treating had received 45 grays or less before, you can potentially give 18 grays in 5 fractions. However, if the patients have received 50 grays before, then you should further limit your spinal cord dose to about 15 grays. Another commonly reported toxicities is the vertebral body fractures. It's more commonly happen if you have if you use single dose regimen like 24 grades in one fractions, and in that case you may have more than 30% chance that you may have vertebral body fracture. But however, if you do a fractionated regimen or keep the dose per fraction lower than 19 grades, the risk should be relatively low, in the range of 10%. Patterns of failure, I would say the most common pattern of failure is in the epidural space. It makes a lot of sense because if you want to do SBRT of the spine, you want to keep the dose to the spinal cord to a safe level. In that case, if you have big epidural component, most of the time that area does not get enough dose to the area. So, however, if you have cases that with tumor, I would say, let's say more than 5 millimeters from the spinal cord, then you should usually be able to give a good dose to the area. And this is a recent study that's presented at ASTRO by Toronto group. In their study, they have used 24 grades in 2 fractions. They have showed that the local control rate is pretty good. At 2 years, it's 82%. And again, the presence of epidural disease predicts for local failure. They don't have any myelopathy, which is very nice. The cumulative risk of vertebral compression fractures in the range of 13% at 2 years. And the risk factors for that would be lytic lesion or mixed lesions, spinal misalignment, and also related to the dose. This is consensus guideline for inclusion criteria for SBRT. In summary, the best patients would be patients with good performance status, less than 5 sites of metastatic disease, and less than 3 spine levels. And patients should not have any spine instability and no epidural component. Radio-resistant histology is also a good indication for spine SBRT. Ideal treatment should be either patients with no previous radiation treatment or at least more than 5 months from their last radiation treatment. And currently, the BCCA is participating in this Canadian trial, randomizing patients to have 20 grades in 5 fractions versus 24 grades in 2 fractions SBRT style. The idea is to see for de novo treatment if SBRT would improve the pain control and quality of life of patients. So in summary, spine SBRT appears to be a good treatment, gives a good local control and pain control. It's usually indicated for retreatment situation, especially for patients with good performance status, minimal sites of metastatic disease, and less than 3 consecutive spine levels. As a de novo treatment, is somewhat more controversial, but perhaps would be indicated for radio-resistant disease. That's all I got. Thank you.